minutes out of your lunch break to listen to me drone about the new ESC pulmonary hypertension guidelines. My name is Ivo, I'm a cardiac physiologist at Manchester Foundation Trust, and I'm going to talk through some of the updates to the most recent version of the ESC pulmonary hypertension guidelines. I'm going to focus primarily on the changes to the risk stratification and assessment, early assessment of these patients, and how BSEcho falls into it, and I'm going to talk through a couple of clinical cases at the end. So we know from publication and real-life experience that diagnosis and management of pulmonary hypertension is challenging. It's normally a late diagnosis in the patient journey, and it's delayed many times because in younger patients, for example, the management of these patients, the physicians who assess these patients, there's a lot of disbelief in the symptoms, more commonly in women. And in older patients, we tend to blame the symptoms in other conditions. pH is not really on the forefront of our minds when we see these patients. The guidelines do suggest and keep banging on the importance of having clear pathways to refer these patients to specialist centres early on in their journey to ensure that the treatment and management starts, because the outcomes will be better that way. So a few changes: mean pulmonary pressure down to 20 millimeters of mercury by right heart cath from 25 in earlier versions of the document, and the introduction of exercise pH as well, with clear guidance and clear cutoffs for this particular presentation of pH. Pulmonary hypertension, we know it's associated with substantially reduced life expectancy, so it needs to be treated early so we can improve outcomes. Quickly go through the classification of pH. They maintain the 5 groups. In our echo labs, the more common group we're going to see is pulmonary hypertension associated with left heart disease, and this is a change in nomenclature in the guidelines. Previously, they would say pulmonary hypertension due to left heart disease, and they introduced this nuanced way of describing pulmonary hypertension associated with left heart disease, just to ensure that the clinician is aware that in those cases, the most important thing is to treat the left heart disease, manage that, and then reassess pH. pH, group 1 pH, primary pH, is rare, but pH overall in older patients occurs in 10% of that population. Again, right heart cath is the gold standard for diagnosis, and this should be a tool that is available to clinicians early on in the journey of the patient. The guidelines use a 3-strata model for risk stratification for patients, and this 3-strata model is suggested to be used early on in the first presentation of the patient, and it's a mixed tool that uses signs of heart failure, functional tests like 6-minute walk test, and in this version of the guidelines, some echocardiographic, CMRI and hemodynamics parameters have been further expanded upon. Therefore, we can use these parameters early on to assess the risk for these patients. Now, for echo, we can see that RA area is included. There's a new ratio that has been introduced I will talk a bit about later on, which is TAPSE by pulmonary artery systolic pressure by echocardiography and the presence of pericardial effusion. Now, these tools are important in screening these patients, so us as echocardiographers need to make sure that we present this data to the clinician in a way that it's easy for them to understand and put in context of the presentation of the patient. So there is a need to educate the physiologists or the sonographers to tailor the reports to the clinicians, and also educate the clinicians to ensure that the information is available and that there's communication is open 2 ways to improve a better outcome for the patient. Now, the new introduction to the guidelines is a 4-strata model that split the intermediate risk into a intermediate low risk and intermediate high risk. In publications since the previous guidelines, we've seen that using the 3-strata model, the 1-year mortality rates were less than 5% for low risk, 5 to 10% for intermediate, and more than that, to more than 10% for high risk. But all the registry data since then has shown an underestimation of mortality rates in intermediate and high risk groups, sometimes up to 20%. So the committee that designed these guidelines felt the need to further look into that and try to better stratify those intermediate risk patients, which using previous guidelines would account for about 60 to 70% of the cases. So this new four-strata model introduces a more sensitive way to look at changes from baseline. So they suggest that these are used in the regular follow-up of these patients, looking at the functional capacity, 6-minute walk test, and BNP and NT-proBNP levels to help further stratify these patients. The data suggests that the mortality, the 1-year mortality rates for these strata is 0 to 3% in low risk, 2 to 7% in intermediate low, 9 to 19 intermediate high, and then over 20% for the high risk patients. So hopefully this will allow for a better therapeutic strategy because it allows for a better differentiation of those high risk patients. In any case, if only 2 of these parameters are available, it is suggested that any of them in conjunction with the NT-BNP, NT-proBNP or BNP are still good enough, as good as using the 3 parameters. There are echocardiographic features also that can be used, and I'm going to talk a bit about them now. Now, echocardiography is recommended as first-line non-invasive diagnostic investigation. It's class 1B. Now, the guidelines suggest that echo should not be a first-line test in the assessment of these patients. These patients should be clinically assessed, and then depending on the clinical suspicion of cardiac or pulmonary disease, they should be referred for further testing. So starting by clinical examination, functional testing such as, or functional capacity tests such as 6-minute walk test, and an NT-proBNP will help decide that this patient is probably to have echocardiographic alterations. Let's get an echo on them. Now, it doesn't completely separate these 2 ways of treating the patient, because if the echo is normal, we need to have ways to let the clinician know to look at other reasons for breathlessness, but it also allows for a more holistic treatment of the patient. I'm going to talk a little bit about how I think the physiologists can help in this. Historically, we know that we tended to look at TR velocity, estimate RA pressure, and that will give us a pulmonary artery systolic pressure in the absence of pulmonary stenosis. Now, the guidelines have moved to probability. Again, this has been the case since 2015, and the BSE have published guidelines that further reiterate that model. Echo is not subjective enough, so let's put the word probability in it and make it very, very clear for everyone. So, again, TR velocity is not easy to get, and it's a non-insignificant proportion of cases where we can't measure TR velocity, and that impairs our assessment. So use of agitated saline is recommended in those cases. Now, the graph is very similar to what we're used to with the BSE guidance and the ESC guidance, and it's predicated on the use of peak TR velocity, and from there looking at echocardiographic signs of pulmonary hypertension. Now, whereas the left-hand side graph is very familiar to every one of us, there's a few changes to the parameters we look in the echo, and those are the addition of the TAPSE to PASP ratio, and the addition to the PA diameter compared to the AR diameter in short axis. Now, we've tried to get people to move on from estimating RA pressure in echo, because that's another source of error that could introduce. So there are suggested values that could be used and that can be used consistently. So if you've got an IVC of less than 2.1 centimeters, that collapses more than 50%. We know that the RA pressure will be somewhere between 0 and 5. It's suggested that we use 3 as the number for assessment. Again, this will be used for one of the parameters. It's not used alone in the assessment of probability of pulmonary hypertension, so it needs to be put in context of the all echocardiographic findings. This is just a quick overview, and now there's a few pitfalls. I've talked about the absence of TR velocity. There are papers suggesting that patients with no TR velocity on their echo, almost half of them end up having pulmonary hypertension by right heart cath. Now, this particular paper focused on the 25 millimeters of mercury cutoff. That now the cutoff is 20 millimeters of mercury, but we can infer that it's going to be a similar proportion of patients, whereas we can't measure TR velocity. So we need to make sure that the quality of referral is good to prompt the physiologist to tailor that report to the clinician to say, even though there's no TR velocity, there are other features that could indicate pulmonary hypertension, and communicate that in a systematic and comprehensive way. Again, I talked about the RA pressure assessment. Sometimes you can't see the IVC. Patients, unfortunately, don't all have very, very good pictures. So when the measurement is possible, even if we can measure the IVC, the accuracy between the echo estimation of RAP and the invasive measurement is still very, very low. So again, the importance of not using any single parameter in isolation. And of course, the absence of TR, not sufficient to exclude pH. So I'm just going to go through very quickly on how to perform some of these measurements. Now, it's important to say that these measurements should be done as part of a routine echocardiogram. There isn't anything out of the ordinary here, and I think it's important to simplify these to people, because sometimes we get a bit scared when you say, oh, now I'm going to say there's pulmonary hypertension. If we stick to the basics and do the measurements we need to do, we can then, in a systematic way, go through the algorithm and try and come up with an answer. So RV size is important to assess. Again, normal RV size and function does not exclude pH. It's uncommon, though, to have significantly elevated PASP with a normal RV. If these are normal in a patient with significant dyspnea, pH is an unlikely cause of symptoms. We also look at the PA size. PA dilates in response to volume and pressure overload. It's measured in end diastole, halfway between the pulmonary valve and the bifurcation. More than 25 millimeters is abnormal. And we also have the new parameter comparing it to the size of the aortic root in the same image. We also can measure the RVOT acceleration time in end expiration using a PW in the RVOT. We need to average 5 beats if the patient is in atrial fibrillation. If the patient is bradycardic or tachycardic, you can correct to the heart rate. If the RVOT acceleration time is lower than 105 milliseconds, that is considered a marker of raised PA pressure. We can also look at end diastolic PR velocity, and any velocity over 2.2 meters per second is considered a marker of raised mean pulmonary artery pressure. Pulmonary systolic notching is an indirect sign of increased pulmonary vascular resistance and poor vascular compliance, in keeping with precapillary pH rather than pH associated with left heart disease. And this is important because when we're doing our report and we notice that there is systolic notching in the PW trace, we need to make sure that that's highlighted to the clinician, so they don't assume, oh, there's a normal LV, there's no valve disease in the left side, there's no TR velocity, but there are signs that there could be pulmonary hypertension. How to measure RA and systole. More than 18 centimeters squared is considered abnormal. IVC, we talked about the limitations of the measurement, should be measured between 1 and 2 centimeters from the RA junction, and if it's larger than 21 millimeters with decreased inspiratory collapse, it's considered abnormal. Again, on RV dimensions, it's important that we obtain an RV-centric view. We need to make sure we can see the RV in its largest dimension to be able to reproduce that measurement. So when we're assessing this patient for the second or third time, we should look at the measurement, we should look at the report, and make sure that the measurements were done in the correct echocardiographic window. The presence or absence of pericardial effusion is also an indicator that we should be looking for. In terms of RV function, the parameters we use more commonly are RVS prime and TAPSE. Again, these reflect myocardial motion, not contraction. It's possible to have a normal longitudinal function in a very abnormal right heart. especially in pulmonary hypertension, you'll see the patients maintain longitudinal function and reduced radial function. Also in patients following cardiothoracic surgery, due to the effects of the geometric alterations, the TAPSE will be reduced. It's not normal, but it will be reduced after cardiac surgery. So we should use fractional area change for assessment of RV radial function. And again, on an RV focused view, to be able to reproduce that measurement in further testing. We can also use the TAE index, which is load dependent. It may pseudo-normalize in conditions with elevated RA pressure, because that will make the tricuspid valve to open early. It will reduce isovolumic relaxation time and underestimate the overall TAE index. And then there's other measurements that I could just quickly glance over. End-diastolic pressure, end-diastolic velocity, mean pulmonary pressure calculation, and RV diastolic function. Now, the BSE guidelines do provide a guide on how to perform this assessment. It's not done routinely at the moment, and to my knowledge, I'm happy to be corrected. But it's important, and it can provide prognostic information. All the data that we need for assessment of RV diastolic function, we already obtained during the standard transthoracic echo. So it's understanding how to put everything together and be able to provide that information to the clinicians. Now, there are a few markers that we can look at when we're assessing these patients repeatedly. Just a few that I'm going to highlight. If the RV end diastolic area increases more than 2.5 centimeters squared from the first echo to following echoes, that's a marker of the increased risk, and that should be highlighted on the report. Same with the RA area, LV eccentricity index, and then we've got our normal parameters that we look at: RV to LV ratio, TAPSE, RVOT acceleration time. So if any of these are abnormal, that suggests an increased risk, and it should be highlighted on the report, and that's one of the main takeaways today. Now, quickly on pulmonary hypertension associated with left heart disease, which is the most common we see in our departments. It's not always easy, especially if there isn't a culture in your department for the physiologist to provide advice to the clinicians, for the physiologist to have that confidence to say, oh, it's pulmonary hypertension associated with left heart disease. So it's important to have education around your echo department with the help of your clinicians, and make sure that our reports are answering the questions they want to know about in a accurate way. Now, when we do an echocardiogram, we know all these things about the patient. We know if they're obese, if they're hypertensive, if they've got left heart disease, we're assessing that, if they've got atrial fibrillation, etc. So when writing the report, we can look at this table, which is provided on the newer guidelines, and say, okay, so let me look at these parameters, and is it likely to be pulmonary hypertension associated with left heart disease, or is it unlikely? And again, if you have that communication with your clinical team, and you have that responsibility to help them direct the patient, use these tools and report your echocardiogram, thinking of the clinicians who are going to read them. Now, this is just a quick overview of the level of evidence. Again, if the patient has left heart disease and pulmonary hypertension, treat the left heart disease first, reassess pulmonary hypertension after that's been done. Again, it's inferred from everything I've been saying. This is a multidisciplinary, I can't say it, I'm really sorry. MDT, thank you. So communication is key, and understanding that because of the number of conditions that can cause pulmonary hypertension, with left heart disease, chronic lung disease, those are the most common ones. So we don't need to look at anything too obscure. We stick to the simple stuff. We know how to assess left heart disease. We know how to assess probability of PH. We just need to be able to communicate that. Now, quickly on patients with systemic sclerosis. Again, multimodal approach is warranted. Echocardiogram alone is not enough. So these patients have several screenings, and they are followed up routinely, and there are different algorithms to help estimate risk, stratify risk for these patients. But clinical features, echocardiogram, pulmonary function test, and NT-proBNP are part of all these algorithms. These patients should be annually followed up, and their evaluation of risk should be assessed in every single assessment. So a quick run through on clinical studies and clinical cases. So the first case is a 62-year-old male presented to the GP with shortness of breath. They've got a raised NT-proBNP, very nice of the GP having done that for us. Atrial fibrillation, hypertension, and obese, and they get referred for an echo as an outpatient. Now, these are some of the echo findings: high TR velocity, short RVOT acceleration time, with potential systolic notching. It's not the clearest I've seen, but I think we can safely say there's some systolic notching there. And then, there we go. The importance of having an RV focused view to assess a radial function. It's visually impaired, we can do all the measurements, and then a short axis view, which I will admit it's not the best, but there is some septal flattening there. If you can't see it, you'll have to believe me, sorry. So, looking at the well-known algorithm, TR velocity is high, over 3.4 meters per second, so that goes straight into the high probability of pulmonary hypertension. Now, we still need to think the most common reason for pulmonary hypertension in our echo lab is left heart disease. So we go through systematically the parameters for left heart disease, and most of the parameters fall into the category of pulmonary hypertension associated with left heart disease is unlikely in this case. So the patient went on to have a CT scan, and they've got a massive PE there. Now, the echo report on this patient must emphasize the severe abnormality in the right heart, and that needs to prompt an immediate reaction by the physiologist or the sonographer to escalate those findings to the clinician. So hopefully, if we see someone like this in an outpatient clinic, we'll get some medical advice before we let the patient go, because it's a very, very abnormal echo. We know the clinical presentation of the patient. It's not the most typical presentation for a PE patient, which just shows us that if we ignore that and say, okay, go back to your GP and reassess, we could be missing something really serious. Now, the second case, a 51-year-old male, presented to valve surveillance clinic with known mild to moderate mitral regurgitation, in atrial fibrillation, and they're normotensive. Now, their echocardiogram shows significant tracheal regurgitation, significant RV impairment, again, a focused view of the right ventricle. TR velocity is high, 4.1 meters per second. Now, it doesn't come across very well, but PR, early diastolic velocity, is increased as well. And then, short pulmonary acceleration time, or RVOT acceleration time, and then no prizes. There's a significantly abnormal mitral valve. So now, again, we know there's left heart disease. There's significant mitral regurgitation, but is the pulmonary hypertension associated with left heart disease? Yes, but we still need to go through the diagnostic algorithm, and then looking at the signs and findings in the echocardiogram, we can safely say that the patient has significant left heart disease, pulmonary hypertension associated with left heart disease. Therefore, the management of this patient should start with the treatment of their left heart disease and then reassessment of pulmonary hypertension status. Now, very quickly, I want to highlight some of the educational resources that we've got as sonographers and physiologists. Of course, there's the Echo Right app, which I've been talking about in the stand all weekend. It's a very good tool for education because it provides a lot of cases. It's constantly being updated, a lot of clinical cases that will take a systematic approach to the algorithm and just a repetition of the parameters that we need to assess. Hopefully that will improve the knowledge of the sonographer. Now, Janssen are very good, thank you for organising educational meetings. We've got an upcoming one in Manchester on pH. We're going to have speakers from a pH centre. We're going to have speakers talking about congenital heart disease. We're going to talk about the echo features of pulmonary hypertension. And there's going to be quite a few local meetings on it, so keep your eyes peeled for that. Make sure you register on all the Janssen platforms, so you get all the emails with information. And also, Janssen are providing access to the 123 Sonography Right Heart Masterclass, online and in person. 15 BSE accreditation points, if that's the reason you want to do it. But it's a very, very good tool to learn a lot about the right heart, not just about echo, but the clinical presentation, the clinical features, and the treatment of pulmonary hypertension. So, moving forward, what I want you guys to take home is think pulmonary hypertension. Early diagnosis is very important, and we as sonographers are in a very good position to help with that. So community echo early on in the presentation of the patient. The creation of professional networks, talk around with bigger centers, get their expertise, make sure you know what they want to know. So when the patient turns up to Sheffield or Bath or wherever it is, they don't have to repeat an echo because we've done a very good quality echo in our centers. Teamwork, staff training, make sure your staff can access all the training resources they need. Make sure there are, and you know them, the clear pathways on how to refer these patients. Help your colleagues tell them how to refer these patients if you think that's the right thing to do. Make sure you tailor your echo reports to the clinician. There's no point in just clicking a box and a drop down and say there's intermediate probability of pulmonary hypertension and give it no context. We should expect more of our physiologists, our scientists, and our sonographers, and we have the knowledge to be able to help with that. And then I think thinking about the development of one-stop clinics to ensure that there's adequate follow-up, there's reproducible results by a specialized team to help treat and diagnose these patients. Thank you very much. If no questions, comments?
Super basic kind of measurement type questions. So what would your tips be for RV focus view for the fractional area change? Because it seems to me that that's not always done really well, and that it can be just pretty difficult to know how far to go into the myocardium and things like that, and how reproducible is it between different observers, etc. And also, if you could just comment on some of the Doppler signs of RV dysfunction, diastolic dysfunction, sorry.
Okay. So in terms of the RV focused view, a practical tip is to have the patient more anteriorly tilted. So tilt the patient, if you scan right-handed, away from you a bit, if you scan left-handed, towards you a bit, and point the probe a bit more anteriorly. But with everything, it's repetition, it's doing the measurement over and over again, and of course, there will be always a source of error, but if you're getting a good RV focused view and you're doing it very often, you will just get better at it, really. In terms of the trace of the endocardial border, it's the same tips as you would with the left ventricle. Make sure you don't include any papillary muscle or trabeculation, and that there is a good image. If you have a good image, it's just easier. In regards to the diastolic function assessments, it's similar in a way to LV diastolic function assessments. We're assessing filling pressure, so TR or transvalvular velocities, E to E prime ratio. They're the same. I can't tell you, to be honest, the cutoffs off the top of my head. But in terms of the stepwise approach, it's getting a PW on the tricuspid valve, it's getting your tissue Doppler. RA size is an indicator of raised RV filling pressure. The physiology is similar to the left side, so the parameters will be more or less the same. Sorry, I can't give you the numbers because I don't know them off the top of my head.
Just a quick question that you are obviously using the RA area as one of the indices, but as you know, it's just a slice from the RA, which is a three-dimensional structure. So, don't you think that we should use right atrial volume index generally?
Well, what I think most of the time doesn't carry much weight. I think RA area has been validated. If it's a good image and it's an right heart focused image, that's the validated measurement. There's people in the audience that can tell you that RA volume, I think, will become might become another parameter to assess, but there are limitations to that as well. Transthoracic views to get RA volumes, 3D RA volumes, are not always possible. They're not very reproducible. Yeah. Therefore, RA measurement is a simple and reproducible measurement that's been validated. So as long as we have a good image and the measurement is done properly, that is, again, it's only one parameter that we use in the whole context, so we don't use just that, but that's the validated measurement. And until the new guidelines come out and new papers come out with other measurements, that's what we use.
Thanks, Eva. That was a lovely talk. Can I just quickly ask a question regarding the use of the agitated saline for better definition of the TR? Is it something that we should be suggesting in our reports, maybe to consider an agitated saline study if you thought there was a high probability of the pulmonary hypertension?
I think that's a discussion that needs to be had locally. In my centre, we've got the facility to, if we think that's necessary for the overall assessment, to try and get a bubble study done on the day, if possible. And we also enable our physiologists to suggest that. And again, it comes to good communication with the clinicians and ensuring that we're not just doing bubble studies for the sake of doing them, but it's having the sonographers having the knowledge to when to refer those patients for bubble study. I think it's underutilized, to be honest. But also, we don't want to be in a situation where we can't get TR velocity, just get a bubble study. Maybe we just need to press a bit harder or turn the patient a bit more. Or it's making sure that the quality of the echo is good, and then all else fails, bubble study. Yeah.
Hi, thanks for a lovely comprehensive talk. I think the absolute key for these people, for me, alongside the diagnosis, is this differentiation of left heart, right heart disease, because as a cardiologist, it is a massive source of low-yield referrals to have people where you kind of review the echo and you're pretty confident it's left heart disease on the transthoracic images. And I loved what you were describing about upskilling and getting confidence in the reporting sonographers to feel that that's the case. And one of the things I find most useful for doing that is the position of the atrial septum, looking through the cardiac cycle, seeing if it bows into the RA constantly, and you're confident there aren't valve disease to be causing that. And I note that didn't make its way into the guidelines. Do you think that's because it's too subjective, or just?
Well, there are cutoffs for us to use to say there's an aneurysmal septum or there isn't. I think personally, and again, it's not backed up by the guidelines as you mentioned, I think it's introducing a subjectivity that might not be. I think it's another sign that we should point towards and we should use in our overall assessment. But how do we, and this is a question I pose to you guys, how do we ensure that everyone assesses it the same way? What might be, there's bowing towards the left atrium. To my eyes, it might not be the same to yours or someone else's. So I think it'd be important to try and ascertain a cutoff, but it's whether there's enough definition on the echocardiogram to say, oh, it's 1 millimeter or it's 2 millimeters. But I think it's something that it's underreported, definitely. I think, personally, and in my center, it's not something that we tend to report unless it's really, really obvious, and definitely it should be something that it's highlighted if it exists. Okay. Being kicked out now, sorry. Can I point you to the BSE AGM, which should start in 5 minutes? Thank you very much.